When Christian invited me to give this talk today, he asked me to talk about the very practical way that we help patients to quit in my center in the United States. So that's what I would like to do. But first, the center that I founded and direct is called the Center for Tobacco Research and Intervention. It's a name that is too long, but nevertheless, that's what it's called. It is part of the School of Medicine and Public Health, and we are a group. Okay, we lost one picture. We're a group of about 50 people who work together in tobacco control. All right, so here are some of the people in front of one of the lakes. And the slides have gotten mixed up a little bit, but we'll just continue. The mission of our center is to reduce the harms that result from tobacco in Wisconsin, in the United States, and in the world. And we really have a national and global mission that we work on together, and we achieve that mission through research, through policy, but also through clinical service. And the center has been in existence for 25 years, and we started as a clinical program. So our origin is directly helping smokers to quit. And that part of our mission, helping smokers one smoker at a time, is very dear to my heart. And it is one of the forces that drives me every day. And I take that part of our mission very seriously. What I want to do is to talk about three things today, and they're all related. I'm going to talk briefly about policy, then describe how we deliver clinical services, and then finally how they're related. And the reason I want to talk a little bit about policy is that frequently what drives smokers to think about quitting and to be open to quitting are external policy forces that encourage them to stop smoking. Whether it's increasing the price through tax increases, whether it's clean indoor air, smoke-free restaurants, smoke-free work sites, whether it is public service campaigns that tell smokers about the dangers of quitting. These external policy forces are going to create for you in your clinical practice many opportunities. And I think even for those of us who are primarily clinicians, an awareness of all of the policy forces I think is important, but also our capacity to be leaders in our communities to promote policies and to attempt to influence more broadly the environment that discourages smoking. So the part of policy that I'd like to focus in on is the fact that in the United States, just 2 months ago, we celebrated the 50th anniversary of the first Surgeon General's report on the health consequences of smoking. And that first report was released in 1964, when, for the first time in my country, there was a national recognition that smoking kills, that smoking is directly responsible for lung cancer and probably responsible for many other diseases. So in our country, we celebrated by publishing a 50th anniversary report. This is just the executive summary of that report, but I thought it was a good opportunity to talk a little bit about policy. And what I'd like to do is just very briefly summarize the 10 key takeaway points from this 50th anniversary report. And unfortunately, this slide did not come up, but what this slide shows is that smoking rates in the United States have fallen from about 44% of all adults in 1964 to 18% of all adults today. So smoking rates are about 1/3 of what they were at the start of our battle against tobacco in America. And this represents enormous progress, decreasing the smoking rates to 1/3 of what they would have been had we continued at the rate of 1964. But we still, well, this is a slide of the release of this report that actually took place at the White House in Washington. And this is the conference room in the White House where the 50th anniversary report was released. So here are the start of the 10 main conclusions from that report. And the first just documents the toll of tobacco in America. 20 million Americans have been killed since 1964 by diseases directly caused by smoking. And if we look worldwide, the toll is so much greater. But I think it's always important not to lose sight of how deadly tobacco has been. And the reason tobacco is so deadly is because the tobacco industry aggressively markets its product to children and adults. And in your clinical work, every day, your messages of cessation and hope and help are messages that have to counter the very powerful, insidious, constant messages of the tobacco industry that is urging people to pick up cigarettes and to continue smoking them. It is important work, but we need to know who our enemy is, who we're truly fighting against, that and addiction. The third conclusion is that tobacco ravages virtually every organ of the body. Back in 1964, they could only say that tobacco caused lung cancer. And today we know that tobacco causes cancer in 20 or more organs. It causes chronic obstructive pulmonary disease. It causes heart disease. The list goes on and on. Literally any part of the body that tobacco or its constituents or its metabolites come in contact with, it causes disease. And in the 2014 Surgeon General's report, they added diabetes, rheumatoid arthritis, and colorectal cancer to the list of diseases that are now felt to be directly caused by tobacco use. Secondhand smoke is also deadly. And when we recognized that in the 1980s, that smoking not only is dangerous to me as a smoker, but is also dangerous to the person next to me exposed to my smoke, it really changed the landscape. And that's, I think, why we are doing so much better in denormalizing tobacco use. I believe we're on the sixth of the major conclusions, that in the past, when smoking was primarily a behavior of men, now in most Western countries, it's equal for men and women. And they frequently say in the United States, because women now smoke like men, women die like men. And unfortunately, the diseases that we saw in the past almost exclusively in men, like chronic obstructive pulmonary disease, now is a major epidemic among women in the United States, and one of the third leading killer of women in the United States. It doesn't just cause cancer and heart disease, but also impacts immune function and causes inflammation. So another whole set of diseases caused by smoking. In the United States, I talked to Christian about this last night, maybe less so in your country, but in the United States, increasingly smoking is concentrated among the poor, among those who have very little education, and among patients with mental health diagnoses and substance abuse diagnoses. And that means the challenge of treating those smokers is even greater, because these are members of our society who often have very few resources. And I mention that in particular for you because as you are treating your patients who smoke, when you have a patient who has comorbid mental illness, it's going to be a much, much more difficult patient to treat. The next major conclusion tells us that there is hope. That if you have a comprehensive program, which we now have in the United States, that discourages children from starting to smoke, that helps currently addicted smokers to quit, and counters the messages of the tobacco industry with public service campaigns, we can reduce smoking. But it takes a commitment from the government, a commitment from those of us as clinicians, and also a commitment of smokers. The second to last conclusion is to talk about the specific risks of combusted tobacco, burnt tobacco. In the United States, 98% of the illness and death from smoking is caused from burning tobacco. And that is our particular challenge, to eliminate combustible tobacco use. The Surgeon General's reports have been very helpful in reducing tobacco use, and that's what this recommendation says. So these 10 recommendations, and for the graduates this year, the 20 or so of you, we've brought a copy of this executive summary for you, so I'm going to share that with you later. But what this tells us is that with a comprehensive program that includes laws like smoke-free indoor air laws and increased taxes, that includes efforts to prevent children from starting to smoke, but in particular includes clinical programs, what you will do in your work. We can reduce and ultimately eliminate tobacco use from our society. I'm going to skip that one. And I want to turn now to talking a little bit about the clinical program we have at the University of Wisconsin. And the most important point I want to make is that this is only how we do it, not that this is the right way to do it or the only way to do it. I really want to make that point strongly because our program has been designed for our population in our setting, and it is a program that works for us, but I would say all of what Dr. Chiamulira and his colleagues taught you over the last year, that is more important than what we do in Wisconsin. So I'm going to talk about the organization, how we've organized it, the different professionals who work in the program, and this type of clinical services that we offer. So, the general organization, we are primarily what we refer to in the U.S. as a referral clinic. So most of our patients are referred to us from other clinicians. So we train doctors across our medical school and the primary care doctors and say to them, we want you to be the first line of treatment of all smokers. That every time a smoker comes into any clinic in our hospital, the expectation is that smoking is addressed in that clinical setting. But it doesn't always happen, and it doesn't always help smokers who want to quit to do so. So they refer those patients to us, often the most difficult patients, often the patients who have failed many times on their own. So we primarily treat these patients that have been referred to us. We also treat patients who call our clinic and say, I want to come on their own. They independently come to our clinic. So those are the two ways that we have patients come into our clinical program. When they do come to see us, they actually see at least 3 different clinicians. And I'll go over the role of those 3 clinicians in our setting. And again, my most important point is, this is the way we do it, but not necessarily the way everybody should do it. So the health educator is usually trained as an undergraduate, not necessarily trained as a clinician. That person completes with the patient an extensive questionnaire regarding their smoking. We send it to the patient in the mail ahead of time, but then review it when they arrive. We do vital signs. We use carbon monoxide very regularly, and I suspect that many of you in your clinics use carbon monoxide meters as well. They serve a couple purposes. One is they give us a sense of how heavy and efficiently the patient is a smoker. But it's also a wonderful feedback loop when the patient quits, to let them see the immediate benefits of it as their carbon monoxide level falls. And we also do pulmonary function tests on all of our patients, both at baseline, before they quit, and we offer them to have that test repeated a year after they've quit so they can see the improvement in their pulmonary function. So the health educator does all that. And next, the patient sees a clinical psychologist who is trained in addiction, who does a comprehensive counseling assessment, provides both supportive counseling but also skills training around quitting, and then makes recommendations to the physician, who is either me or one of the other physicians on the team. So the physician sees the patient last, reviews the notes from the counselor, spends most of the time coming up with a personalized medication plan for that patient, and prescribes the medication. So those are the three professionals involved. It's typically a visit to our clinic of 1 to 1.5 hours. And all of this happens on that one afternoon. And then the patient gets enrolled in a group relapse prevention program, which meets weekly and provides, group counseling support. The group counseling is optional. Some patients come and get a lot of benefit from it, some don't. So that is the core of the clinical program. In terms of the treatments we recommend, the same treatments that you have been taught from the clinical practice guideline and from subsequent research on treatments. But of course, we, as you do, will individualize it to every patient. And the power of knowing what a patient has used in the past, whether it's helped or not, I think cannot be overemphasized. We can learn so much from each patient in terms of their past experience with quitting in guiding us and helping them to successfully quit in the future. And do you know the guideline well? I've got a copy of it here, but I know you know it well. And it's available online. And at the end of the talk, I have a website which will provide all of the resources that I described today. I frequently, when speaking to clinicians across my own country, talk about the fact that the clinical setting is unequal to help smokers to quit. In America, 80% of smokers visit a primary care doctor every year. So they are a captured audience. And if we think about the fact that there are 50 million American smokers, that means that each year 40 million of them are seeing a primary care doctor. And if even a little bit happened at every one of those visits, we could have enormous impact in terms of reducing tobacco use rates in my country. And that's why we focus so much on primary care as an opportunity. The problem is that even in my country, where we've emphasized this for 20 years, fewer than 40% of smokers have their smoking even discussed. They have it documented, they're asked if they smoke, but only about 40% of the doctors say anything about the importance of quitting and how to quit. The counseling is the same counseling that you have been taught. This is obviously just a very abbreviated summary, but if we were to give an overview of what the counseling is reviewing past quit experience. In my country, 80% of smokers have tried to quit at least once and have failed. So we want to learn from what helped and what led to their relapse. We ask the patient to think about challenges to their upcoming quit attempt. We really emphasize the importance of a quit day totally stopping and what that requires. Other smokers in the household, if a couple both smoke, it is so hard for one of them to quit, so we try to treat the family. And then finally, alcohol is a major contributor of relapse, at least in my country. Half of people who try to quit and relapse, if we ask them what they were doing at the moment they had their first cigarette, as they were relapsing, half of them were drinking alcohol. So it's a major contributor to relapse. In terms of medications, I know you have spent quite a bit of time discussing various medications, and there's lots of approaches, but two medication approaches clearly appear to be more effective than the others, and the first is combination nicotine replacement therapy. The use of the patch around the clock, 24 hours a day, and then a more quick released nicotine product like the gum, or particularly the mini lozenge. We use the mini lozenge extensively because it rapidly is dissolved and absorbed. So that combination, or varenicline. That pill is the other combination that is so effective. And these two, while all the medicines are effective, these two are particularly more effective. But it's all individualized based on the patient. So I thought I would just put up a couple patients, and I'm not going to spend a lot of time on this. But some of the things that we think about, the first is a 42-year-old woman who smokes 20 cigarettes a day. She has a history of severe depression and very strong withdrawal symptoms, and her husband also smokes. So when we talk to this woman, she has actually a history of having made a suicide attempt. And because of that, we decided that we would not use varenicline because of the potential risks of that in that individual. We asked her husband to come in, and we put both of them on combination nicotine replacement therapy, as well as extensive counseling and working with them as a couple. The second patient, an older man, a pack and a half, 30 cigarettes a day. He tried NRT many times, but only using the gum and the gum by itself. Did not drink a lot of alcohol. He had never tried any of the pills, and he seemed like a perfect candidate for varenicline, which we used, and we used on him successfully. The last patient is a pregnant female, an enormous challenge because of the fact that she's pregnant. She was a light smoker, had many life stresses, and for this individual, we actually just worked on counseling and intensively provided her with some social support and was able to, for the rest of her pregnancy, be smoke-free. A couple example patients, but I know every day you're dealing with these and others in your clinical setting. I'm going to end with just a couple final points. Something we call treatment extenders, what you can use beyond what you deliver in your clinical setting. And I don't know the status of telephone quit lines in Italy. Christian, is that available nationwide in Italy?
C'è un numero verde dell'Istituto Superiore di Sanità, ma dà solo informazioni.
Solo per informazioni. Allora, in America, we have available across the country counselors by telephone at a single phone number, 1-800-QUIT-NOW, and about 500,000 smokers call and enroll every year. And we use that because the quit line is available 24 hours a day, 7 days a week. So they have that to call if they're having a difficult time away from our program. So it's a resource, but it's different than you have here. What you can take advantage of is increasing online e-health and m-health services. And I'll tell you what we have in the US, but I'm sure you have some such services in Italy as well. They're primarily found, the government services, under smokefree.gov, www.smokefree.gov. They're the base program, but then additional programs for pregnant women, for teenagers, adolescents, for people who speak Spanish. And there are now being developed a whole series of text programs. And I think over time, even if they're not in existence here in Italy today, the capacity to use these mobile applications to extend what we do when the patient is in front of us, I think can be a great extension of what we deliver. I just want to take a moment and talk about this model that we're using in Wisconsin to expand our cessation research. And so much of what the research around helping people to quit has been focused on the patient who is ready to quit that day. And that's a small minority of smokers. So we're increasingly working to develop treatments that motivate smokers not yet ready to quit. And once they are open to quitting, how can we prepare them for their cessation effort? And the terrible challenge of maintaining them. That so many smokers come to our programs, but then don't use the medicines, don't take advantage of the counseling. So how do we increase adherence and maintenance? And finally, what we call relapse recovery, because still a majority of our patients will relapse. So how do we bring them back to try again? So this comprehensive phase-based approach that we've developed in Wisconsin is one that is driving much of our research to expand the treatment options for patients today. I'm going to skip this and that, and I'm going to end with this slide, which shows the rates of smoking in my country. falling from about 44% in 1964 to about 18% today. And it's a remarkably straight line. So we projected in an article to the future and said that if we go at this very slow pace, it's going to take until 2044 to eliminate tobacco use from America. And thus, what I think our challenge is, from a policy perspective, from a prevention perspective, but particularly from a clinical perspective, is how we help more people to quit so that we can accelerate the decline in smoking rates. And it's a similar rate of decline in Italy, so a similar challenge to you. I told you I would share the website that we have at the university. It's designed to, with these icons, particularly for clinicians, healthcare providers, information for smokers. I'd urge you to take advantage of it. Everything is in the public domain. You're free to use it and put your clinic name on any of the materials. It's all publicly available. So with that, I'm going to end and say what I said at the beginning to you who have finished this program, auguri, and to you who are starting it, good luck. And thank you for inviting me to be part of your first anniversary celebration. Congratulations.